Olá pessoal, meu nome é Carolina, eu sou ex-preceptora do programa de medicina interna da USP em 2021 e eu atualmente faço residência de medicina interna aqui nos Estados Unidos. Eu vou mudar para o inglês agora para introduzir o nosso palestrante de hoje. Dr. Mahooti, thank you for accepting our invitation.
My pleasure.
I rotated with Dr. Mahooti about a few months ago and saw him using therapeutic needling, which he'll explain in a minute, and having a patient walk in with a walker and leave without it. So Dr. Mahooti, he graduated from University of Connecticut from medical school. He later went into family medicine, also in Connecticut, and finally did a fellowship in sports medicine at University of Connecticut as well, and currently works mainly treating pain with a specialized talent in therapeutic needling. Dr. Mahooti provides a wide range of techniques to treat acute and chronic pain, one of them being therapeutic needling, which is the topic we chose to discuss today. So Dr. Mahooti, could you tell us a little bit more about what that is?
Sure. So thank you for the opportunity. It's delightful to be able to be with you and to share some of the things I've learned over my journey practicing a combination of family medicine and sports medicine. So as you mentioned, I did a residency in family medicine and a fellowship in sports medicine. And when I started here at Mass General 15 years ago, I had a split practice. Half of my patients were primary care patients, so took care of chronic diseases, all the primary care stuff that we deal with. And also had half of my practice was seeing consultations for orthopedic problems and sports injuries. And over time, I shifted my practice to an entirely sports medicine, musculoskeletal practice. The term sports medicine can be confusing for people, so I think of myself as providing non-surgical solutions for orthopedic problems and sports injuries. I think that's probably the cleanest description of what I do. And that includes a wide variety, whether it be lifestyle recommendations for people or interventions, procedures, education on exercise, on ultrasound-guided injections, therapeutic needling techniques, a wide variety of interventions we can do to help people achieve their goals, get better, and move better.
Yeah, and I guess a big problem that we have as internists or maybe physicians treating pain is that we a lot of times do not know or are not aware of the non-pharmacological interventions.
Sure.
Not even non-surgical, but even like non-pharmacologicals in the era of opioid use.
Sure.
I think that's really relevant to know. So I have a few questions here that were sent to me. And we're going to start with the following question. Would you say there are any clues in the history taking that will make you think of myofascial pain? And even maybe if you could comment a little bit, what is myofascial pain?
Sure. So the term myofascial pain refers to muscle and fascia, which are integrated structures in the body, more or less. The fascia is white. It's the connective tissue lining of the muscle. All of the body is lined. Every organ, every structure in the body has a fascial lining to it. In medical school, when we did gross anatomy, most of us would hack through the fascia in order to get to the nerves, the organs, the good stuff, so to speak. In other areas of education for massage therapists, for example, where they do cadaveric dissection, they cut away all the organs to look at the fascial line, where the fascia run, the different arrangements of fascia. And it's quite remarkable how fascia is organized. And it's been really overlooked as we think of it as an inert connective tissue. But the way it's oriented and how it integrates with muscle is a common cause of a variety of pain syndromes that don't fit the typical dermatomal neurogenic type pain that we think of, or the tendon pain, the arthritic pain. Oftentimes patients will come in with symptoms that are just inexplicable. And one of my favorite sayings when people say it's hard for me to describe it, that's a clue to me that they're coming in with a muscular myofascial component of their pain. I have a table on I have a handout I give to patients that has a number of different symptoms people will describe: heaviness, clumsiness, instability, weakness, burning, tingling. A lot of these are you think of as neurologic symptoms. Some of them you think of as if somebody comes in saying their knee feels unstable, you'd be thinking, did they injure it? Did they have a ligament injury? But often they don't. It's very often due to muscular pain or myofascial trigger points in their thigh, in this example, that causes the sense of instability. Also, they'll sometimes say, my knee is swollen or my leg is swollen, and objectively it's not. They look and you look and it's not swollen, but it feels swollen to them. And I think that's the way the brain kind of interprets the weird sensation in the leg. So those are some clues in terms of the history. But even deeper than that, I would say most patients who present with non-traumatic pain, they haven't injured it per se, they just develop pain maybe after a day or two after an activity, a new activity, or it just kind of comes out of nowhere. I've taught myself over years of this to first rule out the myofascial trigger point component of the pain. So myofascial trigger point, and this is debated in the literature, but the best definition you could think of it is a tight, irritated cluster of muscle fibers that form a knot or a taut band that when you palpate or press can be very tender, considerably tender, more tender than an area an inch or two, a few centimeters away from where the trigger point is. Often it will cause radiating pain, either up or down, that reproduces the underlying pain, but not always, that the patient presents with. And it often will cause a restriction or a decrease in range of motion. So the combination of those factors leans towards there being an active trigger point causing the pain. Sometimes people will have what are known as latent trigger points, where they're not having spontaneous, they're not coming in reporting pain. For example, somebody coming in saying, I have pain in my neck here. That's often due to a trigger point. And you palpate, you'll find a very tight, tender area here, and they're jumping. So if you go and you palpate the other side, they may be pretty tender on the other side. Maybe not as bad, but it's still more tender than you would think or expect. We would describe the left side in this case as a latent trigger point. It's there, but it's not active right now, and they're not coming in reporting left-sided neck pain. But if you ask them, they say, yeah, every now and then this gets bad, but right now it feels okay. The right side is a lot worse right now. So we describe that as an active trigger point, and the other side as a latent trigger point. Now, as you can imagine, if you palpate people carefully, you're going to find these all over the place. So the key is knowing when they're active versus latent, and when do you treat them, meaning when are they the cause of the problem and when are they the result of the problem. That's part of the nuance of understanding myofascial pain. Is most people will have them. If you have any kind of pain anywhere in your body, your knee, your hip, if I poke around, I'm going to find very tight, tender areas. The question I have to answer is that trigger point the cause of the problem or is it the result of the problem? So if you have knee arthritis, you're going to have trigger points in your calf, in your quad, and your thigh muscles. Which do you treat first? Do you treat the muscle, or do you treat the underlying structural problem on the x-ray of the arthritis? That's the challenge.
So it sounds like perhaps if there is something that's causing that myofascial pain, you might treat the myofascial pain, the patient might get better for some time, but if the underlying structural cause of the pain is not resolved, or they don't change the way that they do some movement or their work, let's put it that way, that pain will probably come back.
Yes, right? And that's one of the hallmark symptoms at the follow-up visit. So, for example, I'll see patients, we often describe lateral outer hip pain as trochanteric bursitis, which really isn't a proper term for it, because almost never is there a true bursitis, which is fluid around the tendon, the bursa to the lateral hip. More often it's a tendinopathy, which is a little wear and tear of typically the gluteus medius tendon as it attaches to that outer hip. But even more often I've found is that it's referred pain from tight trigger points in the thigh, the vastus lateralis, the mid or proximal thigh, or in the buttock muscle. And treating those trigger points can often provide immediate relief of the lateral hip pain. Even the tenderness over the greater trochanter will immediately be gone when you treat release the trigger points in the thigh. And the idea, and this is kind of a picture that kind of shows, right? The red is where the pain is, and it can be anywhere along the outer thigh, but the X here represents where the knot in the muscle is. And if you have a tight restricted knot in the middle of a muscle, it's going to increase tension at its attachment sites, and you'll often feel the pain at the area of the attachment site. So you get fooled by it. And I'll often palpate and examine patients in their thigh. They come in and they say it hurts in the outer hip, and I'll palpate their thigh, and they're really tender there, and they'll say, well, that's not where it hurts though. And I say, no, but this is the cause. The lateral hip is the effect of the problem. But if you treat, often I'll see patients who will treat with cortisone or other injections to the lateral hip, to the bursa area, and sometimes it doesn't help at all. Sometimes it helps temporarily. And in those cases, I will typically, if they have significant trigger points, these are patients who are coming in for second opinions, I'll usually start treating, for most of my patients, I'll start treating with the trigger point injection, therapeutic needling technique, and see how they respond. Have them come back in a few weeks, emphasize the role of manual therapies, massage, stretching, and strengthening exercises, which addresses the root cause of the problem, typically, is the weakness and the tightness, and see how they do, and then decide, do we repeat the trigger point procedure, the therapeutic needling, or do we pivot and go after the potential underlying cause with a more interventional, like a cortisone or some other procedure or technique.
And just to clarify a little bit of the physical exam, which was another question. So I guess you showed us a map of trigger point pain patterns. So basically the red will show us the area where the patient will feel the pain, and then this reference guides us towards points where there might be a trigger point causing the pain in that red area, right?
Correct.
Do you mind, I think one case that we saw a few times, and it's pretty common, is the plantar fasciitis. So maybe you could comment a little bit on how a physical exam would look in that case.
All right, perfect. So great case. So very common problem, people with plantar heel pain, kind of the under part of the heel. There's a very specific area called the medial calcaneal tubercle that is typically the site of greatest tenderness. People often describe significant pain in the morning, first few steps of the day, the bottom of the foot it hurts. But if you examine their calf, they will almost always, I can't even think of a case where a person does not have active tender trigger points in typically their medial calf, their medial gastroc soleus. And this picture over here kind of represents this pain. And also with the Achilles. The X represents where the knot is. The red is where the pain is. So sometimes they'll describe tightness in their calf, but they tend to poo-poo it or don't think much of it. Yeah, that's just my muscle, they'll say. And I say, I know that's your muscle. That's the cause of your problem. So a very tight calf muscle, you'll get a knot this area, and that will refer pain to the plantar aspect of the arch or the heel of the foot. And it's very similar. Basically the same area in the calf, when you palpate, can also cause posterior heel pain, where the Achilles tendon comes. So certainly if somebody has an acute injury of their heel, or an acute injury more commonly of their Achilles, you want to make sure it's not a tear or an injury to the Achilles. But very often, if you treat the calf with deep massage, therapeutic needling techniques, lots of stretching, that will significantly help their heel, plantar heel, and their posterior heel pain. And I start there. Almost all my patients, I will try the needling on their calf to see if it helps. It often does. Their follow-up visit in a few weeks is going to tell me if this is a predominant myofascial cause of the pain, or if actually the Achilles or the plantar fascia itself needs to be addressed with an intervention or a procedure. And always, regardless, either way, rehab exercises, working on foot strengthening exercises, heel, what we call eccentric exercises for the Achilles is very important. That's maybe a little bit beyond the scope of the talk here, but that's a very common problem. Heel. It's one of my favorite things to treat is heel pain, because it's almost always, there's a referral component of it from the calf. And if you can address that, you'll substantially help their symptoms, and then they work on, I tell patients, my job is to untie the knot, yours is to prevent it from coming back. And that's where the therapy, massage, stretching, strengthening, all that comes in.
And I guess one thing that I saw you doing in office that's I think it's helpful for them to understand is that you would palpate, for example, where the patient feels the pain, and you would ask from 0 to 10, how much
Sure.
pain do you feel? And then after doing the therapeutic needling technique, which we're going to discuss, you'd palpate the same point of pain, which is not the point where you injected
Sure.
and where you did the therapy.
Yeah.
And they would say, oh, the pain that was a 8 is now a 5 or
less,
it's low
often it's gone.
or gone.
Yes.
Or it would decrease if you did like subsequent injections, right?
Correct.
And then I think this brings me to the other question that was raised, which is, how does this assessment with history and physical exam help you decide if a patient needs or not an imaging?
Sure. So, great question. Imaging, when we think of imaging, we think of radiographs. Typically, we start with advanced imaging. MRIs certainly play a role.
Yeah.
Often I find, if you look at studies on MRIs, and I have a little poster on my wall, that there's numerous studies looking at the role of MRI and how often asymptomatic patients who get MRIs done, they'll show all sorts of abnormalities. We know this. This is well documented in the literature. So I tell my patients, an MRI is not God telling us the answer, but we have to put it in the context of the presentation. And really, the functional problem is the bigger issue, and the function is not always related to the structure. We like to think that it is, and in basic biology we're taught that, but people can have the most common example of this is very often you may have seen patients coming in, they have unilateral, one of their knees hurts. We get an x-ray, and the knee that doesn't hurt is much more arthritic than the knee that hurts.
Yeah.
And the painful knee is attributed to arthritis as well. So the degree of arthritis doesn't correlate with the degree of pain necessarily. Similarly, MRI findings don't always predict the cause of the problem. So if there's trauma, if there's neurologic deficits, use your clinical judgment. But if you're assessing for an orthopedic musculoskeletal problem, it's unlikely this is a surgical issue. You start with typical physical therapy, stretching, massage, home management strategies, anti-inflammatories, and then you have injectable treatments, one being the therapeutic needling or a cortisone injection. Those are kind of the simple starting point procedures. And what I found is my starting point more often than not is the therapeutic needling, because it can be very effective. It can help get patients' pain down substantially so that they can go and rehab it to prevent it from coming back. I think the main point of these injections is not to cure the problem. It rarely does. It's to get patients feeling better so that they can go and rehab it appropriately, which is ultimately their best chance of solving it for most cases. Now, certainly significant injuries and things are going to need to be addressed with surgical intervention or other injectable techniques we do. But by and large, most patients need a lot of rehab, but they can't do the rehab if they're in a lot of pain. So you break their pain cycle, send them to therapy, and then bring them back in a few weeks and see how they're doing and kind of adjust accordingly.
And then the analogy you use sometimes with the chicken and the egg, as far as what we were discussing now, is the myofascial pain a cause of the pain the patient is having, or is it a consequence of something that's underlying there, such as osteoarthritis? So if I don't yet have a diagnosis of let's say osteoarthritis, for example, would it be helpful in that case to use imaging to diagnose that and perhaps correlate that with the myofascial pain, and that would help you understand, should I treat this pain and expect them to improve for a longer period of time, or is there some underlying cause that's going to cause like return in pain in some time?
Sure. No, very good question. There's a few layers to that question, so I'm going to try to answer it and then in parts. The chicken or the egg idea. So this kind of hit me a few years ago when I would see patients who came in with significant structural abnormalities, for example, in their Achilles or their patellar tendon, and I would treat their quad muscle or their calf, and they would have immediate relief of their knee pain if I treated the quad and their heel pain if I treated the calf. But the structural abnormality, I look on ultrasound. I have an ultrasound machine in my office, as you know, that I would look and for diagnostic purposes. It didn't change the structure, but it improved the function. Their pain was better. They're more active. Yeah. They'd often come back a year or two later, and another area would hurt, and I would assess, and I'd, hey, how's your Achilles? Oh, that's doing great. And then I would often ultrasound it, and it looked worse.
I see.
The tendinopathy looked worse, but they weren't having any pain.
Yeah.
And so I think the idea of the chicken or the egg is when you see somebody come in with knee osteoarthritis, they almost always have trigger points in their quad muscles and or their calf muscles. Almost always. It's almost impossible not to find them there. They're very tender in those muscles. The question is, what came first, right? Trigger points are common. Muscles get tight, and these tight muscles create different forces on their attachment sites. Yeah. And if you have a chronic trigger point that is causing a chronic shift in the typical mechanics of the knee joint, over time, a low force over a long time can lead to structural change and lead to the arthritis. Yeah. So typically the thinking is that a trigger point develops as a result of the arthritis, right? So if you read the textbooks on this, you got to treat the arthritis. That's going to help with the trigger point. But if you do a lot of this, and if you think about it, we assert that. We don't know that for sure. If you examine people early on, you'll find trigger points in their quad maybe, and that they're asymptomatic in their knee. But if they come in and they have knee pain, you get an x-ray, it shows knee arthritis, and you palpate their quad and they're very tender, they have trigger points there, that could have been there for 10 years, that trigger point, leading to those mechanical changes resulting in the arthritis. So it challenges the prevailing thinking that the trigger point is a result of the arthritis. It could very well be that trigger point was there many years ago. It was latent. That's important. It wasn't symptomatic. Maybe a little bit of tightness in their leg they felt, but it wasn't causing them pain. And then 5-10 years later, now they're getting pain in their knee, and we get an x-ray and it shows the arthritis. But all along, it's plausible that it was due to the trigger point that's been there forever. Yeah. So that's one of but it's very hard to prove this either way. But it's an interesting idea to think about. And clinically, I see it all the time. I see patients that have significant structural abnormalities, any part of their shoulder, their Achilles, their knee, and I'll needle their muscles around the area, release the trigger points, and they get longer relief than any other treatment we could do for them. Sometimes it's clinically curative, effectively, for them. Yeah.
Which I guess highlights the importance of the history and the physical exam, even more so than the imaging findings in those cases, right?
Correct. Excellent.
And then let's go talk about the technique itself. So I think one term that people are maybe more aware of is dry needling, right? Could you explain a little bit of the difference between dry needling and therapeutic needling, what you do, and how the dry needling techniques applies to your technique as well?
So a great question. So dry needling is described as a procedure using a solid known as a filiform needle, same as an acupuncture needle. And the idea, and this is a very thin, flimsy, not very taut needle that it's inserted through the skin, into the muscle, into the fascia, and you can get a twitch response of the muscle releasing when you use this needle. But it's a filiform solid needle, not a hypodermic needle. A trigger point injection uses a hypodermic needle where something is injected. In the past, steroid was used, corticosteroid was used, but that's been shown to be no advantage to using corticosteroid. So I was never trained to use corticosteroid with trigger point injections, and I never have used them. Some people still do periodically, but the literature doesn't support that. There's been a number of different studies and consensus statements by different pain management organizations that recommend against using corticosteroid for trigger point injections. It can cause muscle necrosis. It can cause blood sugar. Corticosteroids have side effects. We want to avoid them. Yeah. So the therapeutic needling is an amalgam technique of both. So when you're doing dry needling, there's a variety of ways to insert the needle. You can spin it, you can piston it in and out, or spin the needle, trying to engage the muscle and release it. The trigger point injection, the classical way that I was taught, was you palpate the ropey trigger point, you pass the needle into it. There's anesthetic, typically lidocaine, and when you get the twitch response, you inject a little bit of the lidocaine, and then you remove the needle and you poke around, you find the next one, and then you go after that, you inject a little bit, you pull out, and you can find a trail of a line of these oftentimes, upper trap, in the glute, anywhere in the body you'll see this. Mm-hmm. What I, over time, when I started doing I was doing the trigger point injection, the classical technique, and I saw some of the dry needling technique, which is more of a pistoning technique, and I combined the two. Now, there are people who do pistoning with trigger point, mm-hmm. but it wasn't something I was ever taught or saw. And when I first saw somebody doing a pistoning technique, it kind of blew my mind. When I saw it, I was saying, I've been doing this wrong. Yeah. And started applying it, and I've kind of tried different ways of doing this over the years, but I've settled now on using a little bit higher volumes of injectate, mm-hmm. where I combine a little bit of anesthetic lidocaine, like 1 milliliter of lidocaine with 4 milliliters of D5W, dextrose-based IV fluid. Mm-hmm. The dextrose has some nerve calming effects to it, we think, and we often use it for hydrodissection mm-hmm. techniques when we're injecting around nerves or in fascial planes, mm-hmm. where there are adhesions and restrictions. Mm-hmm. And there's evidence to support the use of it's inert. It's basic. It's benign, I should say, for the most part. It doesn't cause harm, mm-hmm. And it can help with with some of the nerve-mediated pain that we'll see in patients with these kind of pain syndromes. So the therapeutic needling, again, a combination of dry needling and trigger point injection, mm-hmm. where pistoning is incorporated. And as I'm needling, I will pass the IV, the injectate into the muscle when I get twitch responses. And often I'll use 5 to 10 milliliters of fluid, depending on the size or the area I'm treating. Mm-hmm. But I'm more liberal now injecting than I used to be. Part of that is, one of the first questions people ask me with this, and I know we're probably getting to this, is how do you not hurt, how do you avoid hurting the neurovascular mm-hmm. structures? Mm-hmm. So great question. That is, when I first started doing a lot of this, I would do it under ultrasound guidance because I was afraid. I saw the technique, the pistoning. I wasn't sure if I was going to hurt. I would look with ultrasound, identify the nerves, stay away from them. And then over the years of doing hundreds and then thousands of these, I stopped using the ultrasound because I found that it was much safer than I would ever imagine. If you watch some of the videos, and it can be terrifying. People look at that and say, "How is that person not? How are you not hurting them, and how are they tolerating that?" But that's pretty common that I see that, and you experienced it. Yeah. But one of the techniques I'll use is when I pass the needle, I will push on the plunger, which in a way tends to work as a snow plowing effect to push neurovascular structures out of the way. And if patients have a little nerve irritation as I'm passing, it's more the fluid, and then I'll redirect my needle. So it's kind of a safety, and I don't have any study to show this, but it's more a technique that I've kind of worked on and developed, and fortunately have had, there's been that I know of any significant injuries to anybody. Mm-hmm. So there's certain body parts that you have to be more careful with. There's neurovascular structures and others that are much safer to treat. Lower risk of having an injury or problem.
So it sounds like there's basically no major contraindications.
Yeah, so contraindication, if you have an overlying rash or an infection of it, that's pretty obvious. You'll read, I have done this safely on patients who are on some of the newer anticoagulants. Mm-hmm. So if you're warfarin, you got to be careful with a little bit. But I do it routinely on patients on clopidogrel or Plavix, on Apixaban, without any. I'll talk to them about it. You may get some bruising, but the risk of like a big hematoma or anything like that is very small. Yeah. So the risk of stopping it, bringing them back, that's higher than the risk of needling it, on my estimation. If you read the textbooks on this, they're pretty strict with some articles describe stopping the medicine for like a week, no exercise for a week afterwards. Don't do it on smokers. Take high dose vitamin C if you're going to do it. And I don't do any of those things. That just puts up a barrier. Yeah. People come in, their elbow hurts or knee hurts, and I go right after it in most cases. Yeah. And I found that works very well, and it's a low side effect profile, other than soreness. Maybe some bruising and soreness you'll get.
And when you mentioned the combination of the way that you needle plus the medication, which includes anesthetic, a local anesthetic, what do you think has the bigger weight on improving the pain? Is it the technique itself of the needle, or the using a medication?
Yeah, absolutely. I think and I wouldn't even call it a medication. It's lidocaine. It's diluted.
Yeah.
It's really more the technique of the needling.
Yeah.
Right. It's finding the culprit, as we call them.
Yeah.
The culprit trigger point or points, the areas that are creating the greatest tension on the muscle at its attachment site, resulting in the pain, and releasing the culprit.
Yeah.
And this is one of the challenges of looking at literature on this. There's voluminous literature on needling, dry needling, trigger point injection. There's books written about it. Dr. Janet Travell, these posters, Travell and Simons, they made this most famous. These are their two big red books, 2 huge volumes. All these pictures come from Dr. Travell's work from decades ago. She was a genius, as was Dr. Simons. He was an astronaut, physician, went up into space, pretty amazing. But she was President Kennedy's physician when he was in the White House. So this has been around for a long time, and this is the newer book that's been put out, written by mostly physical therapists. It's a multi-authored book looking, and this is really, there's a chapter in here on dry needling, which, again, you can get good results with dry needling, but I think there's a study was done looking at dry needling, comparing it to trigger point injection, and trigger point injection outperformed dry needling. But there's always questions with who's doing the needling. Are they their assessment? It's as I've done a lot of this and seen the responses I've seen, I'm biased in it. I think that the technique is really important. And I think that there are I've had many patients come to me who have had dry needling, have had trigger point injections elsewhere. They come and I do it, and the majority of them say that was way different than what I had. And many of them feel better. They get better with it. Not all, but so there's a bit of hubris with this. Definitely. But I think I just find that the technique is really important. And if I have a patient come to me and they've had it done before and it hasn't helped, and they have another issue that could be causing it, I'm on the fence with those, and I'll say, let me just try this for you, because I have a way of doing it that I need to be clear in my mind. I don't want to go off to the cortisone injections and more invasive, expensive, interventional things until I'm sure that this isn't causing your pain. So let me try it. And most of them say, okay. Yeah. And I probably have a mixed response. A fair number of those get better without me having to go on to the next thing, which I would say, was my technique better? Did something evolve or mature over time? I don't know, but I still typically offer that for patients before we jump to the next thing.
And I guess with everything in evidence-based medicine, it's really the risk and the benefit.
Yes.
And it sounds like from everything that you explained, it's a very low-risk procedure. There is a fairly high response in patients that have an exam that really shows that there's a myofascial pain there, or there's a component of myofascial pain to their total pain. And so I think the overall message is it would be worth trying, but obviously it's very professional dependent and
technique,
and technique, and like everything with technique, the more experience you have in it, the better you get. I think you mentioned that you found like trigger points that you didn't even think could exist for right. So
great. Referral patterns, like you can see the post, as I've done 15, 20,000 of these over the years. There are referral patterns that are marked here that are not marked here that are I see pretty commonly. One example with this is a patient who came in with chronic kind of low back pain that was all related to a cluster of trigger points in her buttock and her gluteal muscles. You can see that here. This is a very common presentation. And I explained it to her, and I treated her and her glute, and she got up and she said, yeah, my back is gone, my pain's gone. And you know what? I had this chronic neck pain. I didn't tell you about that, and that feels better, and was moving her neck around. So the way that this is that referred pain, and where the fascia restrictions, we're talking about the cadaver studies before. If you understand the way fascia runs throughout the body, you can start to make sense of why treating the glute or the hip area is going to help neck pain, the way the fascia runs. It's not every day, but it's pretty spectacular when that happens.
No, that's true. Dr. Mahooti, this was super interesting, and I mean, you know that I was amazed when I came here. I think I've always felt that I'm not good at treating pain. I think we lack the understanding of the non-pharmacological and surgical interventions to treat pain. I think pain is something that worsens quality of life, and we see it all the time when we work with internal medicine or family medicine or sports medicine. So thank you for shining a light on this topic.
My pleasure. Happy to help. I'm not sure if it's appropriate, but I'll share with you. It's part of the burden I've carried over the last decade of trying to explain this to people, teach people. I've developed an educational website, therapeuticneedling.com. I have a number of videos there. It's a minimally viable product right now, and I'm trying to raise more funding for it so I can put more videos and do more teaching. Everything we talked about, make that more professional, have question and answer, short videos demonstrating technique. So that's a resource if anybody's interested in checking out therapeuticneedling.com.
Definitely check it out. I think seeing is even more informative than everything else.
Yeah, and that's when I first saw that pissoning technique. I was at a meeting and it just blew my mind.
Yeah.
And having had, I do a lot of injections procedures and trained to do them, so I was more not as afraid to go and try them when I came back to my clinic.
Yeah.
But it was from seeing that on a video of a patient that it was very similar to a patient that I had struggled caring for. This doctor was treating the buttock. And as soon as I saw it, I said, that's it. That's what was probably causing that patient's pain of mine from a year or two ago that I couldn't figure out. And it led me on this journey, and here we are. So
that's perfect. All right.
Very good.
Thank you so much.
My pleasure.